This week we'll be talking about respiratory tract drugs. First, we'll review drugs used for asthma and COPD. First, we'll look at the pathophysiology of asthma to help us to better understand how the medications work to help our patients that deal with this chronic inflammation disorder of the airways. Approximately 50% of children with asthma and in some adults, the airway inflammation will actually result from an immune response known as an allergen. And in some children and adults, the cause of their airway inflammation is actually unknown, or it just has not yet been identified, meaning that there may be allergen suspected, but the provider may not have finalized or come to a conclusion on what that allergen is. You can see here in this figure the events that could lead to the inflammation and the bronchoconstriction in our patients that have asthma. Inflammation and bronchoconstriction is an important aspect to understand about the disease process of asthma. And although this image doesn't really show everything completely about all asthma patients, it does give us a basic understanding on how the drugs that we use for asthma can help treat this disease. Recalling pathophysiology, the inflammatory process really will begin with the binding of the allergen molecule. So take, for instance, maybe dust mites or dust in general. It could be pollen, grass. This binding of the allergen molecule to the immunoglobulin E, or what we prefer to call IgE, antibodies on mast cells. And this causes the mast cells then to release all types of mediators, specifically histamine, leukotrienes, prostaglandins, and interleukins. These mediators have two effects. First, they act immediately to cause more bronchoconstriction. Additionally, they're going to promote the infiltration and activation of all the inflammatory cells. Remember, eosinophils, leukocytes, macrophages, and that's what causes the inflammation in the airways. The inflammatory cells then are going to release mediators of their own. And what do we have as the final result? We're going to have overall airway inflammation, which we'll see with edema in the airway. We'll have mucus plugging and smooth muscle hypertrophy. All of these things are going to obstruct airflow. Therefore, asthma is a chronic inflammatory disease of the airway that causes bronchospasm, inflammation, and obstruction of airflow. Now, additionally, this inflammation is going to produce this state of bronchial hyperactivity, even with mild triggers like cold air, exercise, tobacco smoke. All of these things can further intensify the bronchoconstriction of our patients. The more common signs and symptoms that our patients will come in with are sense of breathlessness or shortness of breath. They have this tightening in their chest. You'll hear wheezing, dyspnea, cough, and you can see visible signs of sometimes retraction, intercostal space bulging, all caused by this immune-mediated airway inflammation. Just like asthma, learning about COPD will help us understand the drugs that are used to treat our patients. Now, COPD largely is a combination of two pathological processes. First, we have chronic bronchitis and we have emphysema. Okay, so emphysema is a component of COPD. Sometimes that connection gets mixed up. In most of our COPD cases, both processes are caused by an exaggeration of the inflammatory reaction, and it's through long-term cigarette smoking. With chronic bronchitis, which we defined as chronic cough with sputum. Chronic bronchitis results from hypertrophy of these mucus secreting glands in the epithelial cells of the larger airways. With emphysema, we are going to have enlargement of those air spaces within the bronchioles and the alveoli. This causes deterioration of the walls of these air spaces. When our patients with COPD come in, they complain about chronic cough, excessive sputum production, wheezing, dyspnea, and they have very poor exercise tolerance. The relative contribution of the two processes that we talked about will vary, and in some patients, it's primarily bronchitis or that chronic bronchitis that causes most of their symptoms or is attributed to most of their symptoms, and sometimes it's primarily from the emphysema or the enlargement of the air spaces. Many times it is a combination of both. So when we're thinking about how to treat our patients, we have to get a good understanding of the history, the signs, the symptoms, and when they were diagnosed with COPD. And when they have that diagnosis, it does require spirometer testing. And what we're trying to measure is the post-bronchodilator forced expiratory volume in 1 second over the forced vital capacity of less than 0.7. This is needed to confirm the diagnosis. And so often you'll see FEV1 over the FVC. And so we're looking for something less than 0.7. You can see in this figure the events that actually lead to the inflammation, the obstruction of airway, and the air trapping that happens with COPD. Things that will cause more irritation are largely it's tobacco smoke that will initiate the inflammatory response within the airway. And as a result of the frequent recurrent irritation, we'll see leukocytes and inflammatory mediators, pathologic changes in the bronchial edema, and all of this is going to cause a large increase in the mucus secretion. And this is actually what characterizes chronic bronchitis, chronic cough with mucus production. Additionally, we're going to see continuous inflammation, and this inflammation inhibits the production of protease inhibitors. This has a protective role in maintaining alveolar integrity. With this inhibition, these protease enzymes will break down elastin, which results in the destruction of the walls in the alveoli, and it decreases the elasticity or the recoil. This is all characteristic of emphysema. There is a small percentage of the population where emphysema will result from genetic alterations instead of triggers like cigarette smoking. Many of the medications that we use for asthma are used for chronic obstructive pulmonary disease because they're both diseases that obstruct the airway. The two major drugs that we use, you can see here on this table, they fall into two main classes: anti-inflammatory agents or bronchodilators, because we have bronchial constriction and we have inflammation. So respectively, these are the classes that are going to help us to help our patients with their symptoms. The primary anti-inflammatory drugs that we use are glucocorticoids. So glucocorticoids have this anti-inflammatory response that will help reduce the inflammation caused by the irritant or the allergen. Now, the principal bronchodilators, these are the beta 2 agonists. And for someone that has chronic asthma but has stable COPD, we can use glucocorticoids administered on a fixed schedule. And this is almost through the route of inhalation. With beta 2 agonists, many of the times we are going to administer this also on a fixed schedule for long-term control, but we can also use it for a PRN or an as-needed basis. And when we do this, it's really to manage an exacerbation or acute attack. Like glucocorticoids, our beta 2 agonists are usually also in inhaled form. You can see the different types of anti-inflammatory agents here. We have many to choose from. Prednisone, cromolyn, beclomethasone. Bronchodilators include ipratropium, tiotropium. Most popular is albuterol, but we also have salmeterol, theophylline as bronchodilators. Our leukotriene receptor agonist, remember the by antagonizing the receptors for leukotrienes, we actually will help with the inflammation process. And so we have montelukast, which is one of the more popular ones in that class. We also have the ability to use monoclonal antibodies, and those are all the drugs that end in MAB. We can use phosphodiesterase, or roflumilast is an option as well. And as we talk more about asthma and COPD, you can understand these drugs a little bit better. What I would love for you to do is to go through all of these drug classifications and write out the mechanism of action, the more common side effects, and the combinations of the drugs. What combinations are they provided for us in? Additionally, we can also use anticholinergic drugs and combination drugs like I alluded to earlier. There are glucocorticoid and long-acting beta agonists, and we have beta adrenergic agonists and anticholinergic forms that come in combinations. And so it will take you a bit of time to remember these combination forms, and most providers will pick according to the formulary that is available or patient's insurance, but you will see a repeat of many of these drugs being used. Like for instance, with the beta 2 adrenergic agonists, many of the time salmeterol is prescribed, albuterol is prescribed. So you're going to see a lot of these things come up in your practice, in your clinical sites, and you will further discuss with your preceptor which drugs are their preferences and why. Also, patients that have been accustomed to certain types of medications already, and if they're working, they'll continue to use them. So we have newer drugs and drug combinations, but with these disease processes, if they are working well, we try not to change it unless there's an issue. We're moving on to drugs for allergic rhinitis, cough, and colds. And remembering that allergic rhinitis and colds, these are pretty universal. Although they're not very devastating in terms of how sick someone may get, the patient who's being affected with these signs and symptoms usually don't feel very well, and it interrupts their life. They don't feel good. Unfortunately, the drugs that we prescribe or use to help allergic rhinitis or colds, they are often over-the-counter drugs. They often don't really help their symptoms too much, but we are trying to help manage the associated symptoms to improve the patient's ability to cope with the symptoms. So the things that you want to think about are antihistamines, glucocorticoids, decongestants, antitussives, expectorants, and mucolytics. And those are the drug classes that you have to remember and understand are used for allergic rhinitis or the common cold. Now, the drugs that we're going to use in this chapter talk about, they're prescribed to alleviate symptoms that are common in the upper respiratory disorders or the etiologies that come from the upper respiratory system. And most of these have already been discussed, but we'll shine a light on some of the ones that stand out. So first, the drugs that are used for allergic rhinitis, allergies, inflammatory disorder, and it affects the upper airway. So many of the times our patients are going to come in with sneezing, rhinorrhea, pruritus, nasal congestion. All of this is caused by the dilation and permeability of their blood vessels within their nasal passages. In addition, some patients experience associated conjunctivitis. They might have sinusitis and asthma. These symptoms are usually triggered by allergens that are airborne and bind and activate IgE antibodies on the mast cells. And just like we've seen in the process with asthma, they are going to release leukotrienes, histamine, and inflammatory mediators, including prostaglandins. With allergic rhinitis, the most common of the allergic disorders, you will be prescribing medications very often or seeing patients with these symptoms very often because 1 out of every 6 people living in the U.S. has or has been affected by allergic rhinitis. And we have 2 major forms. We have the seasonal and the perennial. Now, seasonal rhinitis, which we sometimes will refer to as hay fever, this happens in the spring and the fall, and it gets triggered by outdoor allergens primarily. Think about pollen from weeds, grasses, trees. Perennial, which means non-seasonal, just like when we have perennial flowers, they can be year-round. Perennial rhinitis usually gets triggered by indoor allergens, dust mites, pet dander, something in your internal environment, internal meaning indoors. Now, there are several drug classes that can also help with allergic rhinitis as well. And primarily, these are going to be intranasal glucocorticoids, oral or intranasal antihistamines, and we'll use sympathomimetics that come in oral and intranasal form as well. You can see on this chart how they work. With glucocorticoids, they're going to prevent inflammation to the allergen response, but they do have some side effects. Sometimes it causes nasal irritation because it's being provided in the nasal route, and there are some studies that show that long-term use of glucocorticoids actually slow down the linear growth of our pediatric patients. Now, antihistamines can block our histamine 1 receptors, and this is what we want so that we can decrease that sneezing, rhinorrhea. But it doesn't really reduce congestion. We need something else for that. The adverse effect for antihistamines is that it really makes you tired, and we also can see anticholinergic effects, and most of the times it's with our first generation antihistamines. Cromolyn is something that some providers like to use because it doesn't have adverse effects, and it prevents the release of the inflammatory mediators from the mast cell. So it's starting right at that point of inflammation process. And it's trying to help decrease all the symptoms. Yet when you use cromolyn, we don't get a lot of efficacy from it. The sympathomimetics can also be used intranasally or orally, and they activate the vascular alpha receptors, and they cause vasoconstriction. When we have this vasoconstriction, we're reducing nasal congestion by doing so. However, it's only working on that part of our allergic rhinitis, but it's not going to decrease your sneezing, your itching, or your rhinorrhea. Many times, people will complain about insomnia, and it will increase their blood pressure. With anticholinergics, the main adverse effect is drying everything, right? Because that's what anticholinergics do. They dry our nasal passages, and it can cause irritation because we're giving it intranasally. But with anticholinergics, it's going to block the nasal cholinergic receptors, and by doing that, it's going to reduce secretions. It's drying everything out. So then this is going to help with sneezing, the nasal congestion, or the postnasal drip, or all of them if that's what your patient has. And then lastly, if we use anti-leukotrienes, which are only provided orally, we can block the leukotriene receptors that are activated when our mast cells are activated, and this is going to reduce nasal congestion. Usually, we don't see any side effects from using anti-leukotrienes, but rarely we will have neuropsychotic effects. Now that you can see how complicated and multi-layered treating allergic rhinitis is, you can understand why there are so many different over-the-counter medications for allergic rhinitis and combinations of these drug classes in one brand's cold remedy. The drugs that we use for coughs are antitussives, expectorants, and mucolytics. The antitussives are the ones that are going to actually suppress the cough reflex. And cough is a complex reflex, and it involves your CNS, it involves your peripheral nervous system, and your muscles of respiration. This reflex is initiated whenever there's irritation anywhere in the bronchial lining, the bronchial mucosa, as well as being stimulated by any sites that are distant from the respiratory tract. Now, cough isn't a bad thing. We have this mechanism that can be very beneficial because it's trying to remove anything foreign or try to help excess secretions from entering the bronchial tree. For example, if we have a productive cough, this is going to help us to expose irritants or foreign matter that shouldn't reach the rest of our respiratory system. This productive cough is characteristic of chronic lung disease. Think about emphysema, asthma, bronchitis. And we don't want to suppress it because we need for all of this to come up and be released. So that production is good. But not all cough is good or useful. When we have a non-productive cough, it's very uncomfortable. It's hard for patients to sleep, and using a cough suppressant for those type of patients is appropriate. It's not appropriate to use a cough suppressant in those disease process where we need that production of cough to help remove the irritation, the phlegm secretion. The most common use of cough medicines is actually a cough suppressant for non-productive cough. And these non-productive coughs are the ones that are associated with the common cold and other respiratory infections. So antitussives, these are the drugs that suppress the cough. They act on the CNS and peripherally, and they fall into two major groups. We either have antitussives that are also opioids, or we have the non-opioid antitussives. And it's really interesting. Although the major antitussives like codeine or dextromethorphan and diphenhydramine are clearly effective against chronic non-productive cough, there's no good evidence that these drugs can suppress cough associated with the common cold, but they are still prescribed. Now, the opioid antitussives. Opioids are analgesics, and they have the ability to suppress the cough. There's two that we use primarily. We mentioned codeine. We also use hydrocodone. And these drugs are going to act on your CNS to elevate your cough threshold. Therefore, using hydrocodone can actually be more potent than using codeine, and it carries a larger liability for abuse. Most of the times we would prefer to use a cough syrup with codeine instead of hydrocodone. The basic pharmacology of the opioids we've already discussed, so we're not going to go over this on this slide. Now, codeine is the most effective cough suppressant that we have, but not everybody needs codeine. The drug is active in its oral form, and it can decrease the frequency and the intensity, but we're only using very low doses, and we're only trying to use enough to relieve the pain from the cough. If you use more, you put the patient at risk, but this risk is very small for physical dependence. Sometimes this is a common concern for our patients, so you have to explain to them that the risk is very low for chemical dependence. Now, like other opioids though, codeine can suppress respiration. Now, the drug should be used with caution, especially if we have patients that already have reduced respiratory reserve. If there's an overdose, we're just like we would do with a different type of opioid overdose, we need to find an opioid antagonist. And for instance, we would use Narcan or naloxone. And this is going to reverse any toxicity from overuse of codeine. Now, when used by itself, it does have a very high significant potential for abuse. And when it's prescribed by itself, it's under the Schedule 2 of the Controlled Substance Act. But when we mix it up with an antitussive, this is going to lower the contents of codeine. It's actually pretty low. And then this mixture is classified under a Schedule 5. When we treat cough, the usual dosage is going to be 10 to 20 milligrams PO 4 to 6 times a day. And rarely would we prescribe codeine to our pediatric patients. Now, what's much more popular to treat cough is the antitussive called dextromethorphan. And this is the most effective over-the-counter non-opioid cough medicine. And we use it most widely in all the cough syrups that you see over the counter. You're going to find this ingredient, dextromethorphan. Now, like opioids, dextromethorphan acts on the CNS, and it's actually a derivative of the opioid. However, it doesn't produce those typical opioid-like effects like euphoria. It's not going to cause physical dependence. But when you use it in high doses, you can actually have some of these effects like euphoria. And many patients can also form an addiction to dextromethorphan if it's being used and abused in very high doses. Now, when we use dextromethorphan, you want to make sure you're only prescribing a therapeutic dose. And although dextromethorphan doesn't depress respiration, you still have to be cognizant and careful about how you prescribe this, and even though it's over the counter. Now, the adverse effects are going to be mild and rare, but the active ingredient in a non-prescription cough medicine is 100. Actually, it's more than 140 non-prescription cough medicines. This is what you're going to find as an active ingredient. Okay. And the usual dose is 10 to 30 milligrams that you would take PO every 4 to 8 hours. So dextromethorphan, if someone does want to abuse it, it's very easy to do if they want to overdose on over-the-counter dextromethorphan. Again, you can find it in over 140 non-prescription cough medicines. Now, in the past, it was considered not being able to have an analgesic effect. It was just suppressing the cough. But now, with more studies, it does actually show that this drug, dextromorphin, can actually reduce pain that comes with the cough. And the mechanism is the blockade of receptors for the N-methyl D-aspartate, or the NMDA, in the brain and the spinal cord. So, if we're comparing the two, opioids relieve pain primarily through activation of the mu receptors, but dextromorphin has minimal analgesic effects when it's used alone because it's only working on the NMDA, the blockade of the receptors of the NMDA. The other two classes are expectorants and mucolytics. Expectorants are going to help the cough to be more productive, and it's stimulating the flow of respiratory tract secretions. And we're trying to bring up those secretions and cough it out. There are a variety of compounds like ammonium chloride, iodine products that promote this suppression or expectorant action, being able to cough something up. But however, in most cases, the efficacy is questionable. Think of guaifenesin, which is the more common one. Think of Mucinex, which is guaifenesin. This is the exception. This drug, to be effective, you have to use high doses than normally employed. And then the last is mucolytics. This is a drug that reacts directly with your mucus, and it makes it more watery, a little bit more thin, to help your cough to be more productive, to be able to get it out. And there are two preparations. You can use a hypertonic saline or acetylcysteine. These are going to be used as mucolytics because of that action that they provide. Now, most of the time, mucolytics can be administered by inhalation. Unfortunately, both of these can trigger your bronchospasm. So you want to make sure that you're watching carefully, you're educating your patients, and you make them aware that this is a side effect. Now, because of the sulfur content in mucolytics, acetylcysteine specifically, it smells like rotten eggs. So most of the time, patients don't want to take the mucolytic. In terms of treating the common cold, we think about acute upper respiratory viral infections, and about 50 to 80% of colds are actually caused by the human rhinovirus. And this can cause serious infection of the lower respiratory tract. And what you would see is rhinorrhea, nasal congestion, cough, sore throat, sneezing, a little bit of headache, hoarseness in your voice, malaise, myalgia, and fever is more commonly a symptom in children, but not as common in adults. We, because we've all had a cold, know that they are self-limiting and they're usually benign, but as the symptoms worsen or become persistent, then we think that maybe we have developed secondary bacterial infection to that primary viral infection. There is no cure for the cold, so our treatment is purely just trying to alleviate the symptoms. And because colds are viruses, there's no justification for antibiotics unless there is a secondary bacteria infection or bacterial co-infection that arises. There's no evidence really in the literature that supports vitamin C or zinc to prevent or cure colds. However, many people do add it on to their regimen with their patients. I don't think that it harms it, but there's not a lot of strong evidence. And because no single drug can alleviate all the symptoms, the pharmaceutical industry has created many cold remedies that are a mixture of the ingredients, which we talked about when we went over the antitussives and the mucolytics. The combination cold remedies should be preserved for patients that have multiple symptoms. So you don't want a cold combination drug that has maybe an antitussive if they're not coughing. You don't want something that is a mucolytic if they don't have mucus. So when you are advising your patients for over-the-counter drugs, make sure that they understand this as well, because they could just get the relief of symptoms from a single drug cold remedy. And so things like rhinitis isolated by itself, or cough isolated by itself, or even headache isolated by itself would be a better option in this case. So we will talk about the over-counter cold remedies that are a combination of nasal congestants, antitussives, analgesics, sometimes antihistamines if you are trying to pursue the cholinergic actions, and caffeine. And this is trying to offset the antihistamine that usually makes people drowsy. Now, the purpose of the first three are pretty self-evident, but sometimes the use of antihistamines and caffeine is confusing. But going back to histamine itself, now histamine has nothing to do with cold symptoms, but the purpose of including an antihistamine is to block the histamine receptors. So rather, because the anticholinergic actions, antihistamines are sometimes included to suppress mucus secretions, because those mast cells can activate the goblet cells to create mucus. Now, histamine reaction that is more common with allergies, so we're using it for a different mechanism. Now, this action actually can potentially worsen the upper respiratory infection because it's thickening your secretions, making it more difficult to drain. And when this happens, you are making a situation sometimes worse because bacteria like this type of environment. So what started off as a viral cold, you can turn into a co-infection with bacteria pretty fast because you are creating an environment that's conducive to bacterial proliferation. Now, caffeine, again, is added. It's trying to offset that sedative effect of antihistamines, but also it can help with some associated cold headaches. Now, it can be convenient to take a combination cold remedy, but the disadvantage is that you're taking medications that you don't really need. Now, with fixed dose combinations, there's a chance that it's going to produce a therapeutic level of one ingredient, but maybe you're getting excessive levels of the other ingredient, or not enough, or subtherapeutic levels. Let's say, for instance, you really need it for the analgesic reaction, but you're getting high levels of antitussive when cough is really not the issue. Additionally, that combination is containing ingredients that your patient just overall does not need at all. So please keep this in mind. The FDA, or the U.S. Food and Drug Administration, does have regulations. So a brand name product can be reformulated and then sold under the same name. So when you are maybe buying NyQuil cold and cough remedy or something like that, it could actually change the levels of the ingredients overall, and still use the same name. Okay, so make sure you are reading the label, you're telling your patients to read the label, and educate them that they may not need a combo product at all, because it all has to go back to marketing. For our younger patients, our pediatric patients, many healthcare experts believe that we really shouldn't be using over-the-counter cold remedies for our children, and there's not really proof of efficacy or safety for our pediatric patients, and there is, however, proof that it could cause potential and serious harm. So according to the CDC, there are thousands of children that have been taken to the ED for management of adverse effects related to cough and cold products. So please make sure you educate your patients' families to let them know that they need to consult with the healthcare provider before trying these over-the-counter medications. So what are they presenting to the ED with? Well, some of the things that they have come in with were actually convulsions, tachycardia, hallucinations, and impaired consciousness as well. And in severe cases, children have died from over-the-counter cold and flu medication. In about 2008, the FDA recommended that the over-the-counter cold remedies were not given to children below the age of 2 because under the age of 2, it does pose an increased risk of potentially life-threatening events. Now, we do still have some things under review. The FDA is still looking into the safety of drugs from the ages of 2 to 11. But in the meantime, you just want to make sure that you let them know it does have very low efficacy, very high risk, and overall, it's just not going to be adequate in being effective to reverse any of the symptoms. And if they come in with any of these impaired symptoms like convulsion, tachycardia, hallucination, and impaired consciousness, it's really difficult to reverse these symptoms. So the AAP, or the American Academy of Pediatrics, does recommend restricting the use of cough and cold medicines to children under 6 years old.